Hello and good evening to all the students. Welcome to the discussion session of Monday Midday Quiz. Can you please let me know in the chat box if my audio and video is good? I'm waiting for your message so that I can start the discussion. Hello, Dr. Siddiq. Hello, Dr. Anuj. Right. Okay. So I think all good. We are good to go. So let's start. So at the outset, let me tell you that this is going to be a very short and crisp discussion of the 10 MCQs that were asked in the Monday Midday Quiz. So Monday Midday Quiz is an initiative by DocTutorials wherein on every Monday, we conduct short topic-based quizzes. Okay. And so basically, it is just to give you a target and you prepare according to the target. And the winner of the Monday Midday Quiz will win a stethoscope as well. And this time the topic was Pulse and JVP, the two topics for the Monday Midday Quiz. And in the discussion that is going to happen for the next 15 to 20 minutes, I'll be discussing only the salient points. This is not a test and discussion type of session where I'll be dissecting through each question. I'll only be just telling you the salient points on why the option is the answer. Okay, let's start. So first of all, regarding question number 1, which of the following statements is true regarding the examination of arterial pulse? So the true statement is being asked. Let us quickly see each option. The first option says a reduced volume brachial pulse with a late systolic peak is the most characteristic finding in patients with severe aortic stenosis. So the first question is regarding, or the first option is regarding a patient with severe aortic stenosis. So in severe aortic stenosis, yes, there is a late systolic peak. There is no doubt about it. There is a late systolic peak. If you see this image on the comparison of normal pulse with the pulse of aortic stenosis, you can see that the pulse is of relatively low amplitude, which is the pulsus parvus. And you can see the peak also is achieved later in comparison to a normal pulse. So it is a slow rising and late peaking pulse. So yes, in severe aortic stenosis, you can get a late systolic peak. But again, the issue here is the character abnormality is best appreciated in the carotids and not the brachial pulse. So since the first option is mentioning regarding brachial pulse, I cannot choose it to be the true statement. Coming to option number B, a Bispherians pulse is characterized by a systolic and then a diastolic peak and is typical of mixed mitral valve disease. So in case of Bispherians pulse, you will get 2 peaks in systole. So you can see that the option says a systolic and then a diastolic peak, which is wrong. In case of Bispherians pulse, which I have depicted here, this is normal pulse and this is a Bispherians pulse. So in Bispherians pulse, what are you seeing? You are seeing 2 peaks and both the peaks are in systole. Okay, so option B is also wrong. So I'm eliminating option 1 and option 2. The third option says the carotid artery is the blood vessel used to best appreciate the contour, volume, and consistency of peripheral vessels. That is wrong. If you want to appreciate the contour, volume, and consistency of peripheral vessels, you will be looking for either the brachial artery or the radial artery and not the carotid artery. So I eliminate option C as well. What about option D? In coarctation of aorta. So let us try to understand that in coarctation of aorta, the carotid and brachial pulses are usually bounding and rapidly rising and they have got larger volumes. But the lower extremity pulses, like the femoral artery, will have a reduced systolic pressure, a reduced pulse pressure, with a slow rate of rise and late peak. So the femoral artery, you must understand, will have a, as said in option D, it will have a late peak than the brachial pulse, and hence the answer is option D. So I hope the first question is clear for you. So can you please let me know if that question is clear? Dr. Sadiq, Dr. Anuj, Dr. Harigaran. So I hope it is clear for you. Okay. So let's move to the next question, question number 2. Okay. So the question number 2 says, infections due to the following organisms can cause Faggot sign. So this is a previous NEET PG question as well regarding Faggot sign. So let us try to understand what is Faggot sign first. Faggot sign is another name for relative bradycardia. So what is relative bradycardia? In a normal individual, for every 1 degree Celsius or 1.8 degree Fahrenheit increase in core temperature, the heart rate will typically rise by 15 to 20 beats per minute. And what happens in relative bradycardia is there is a lower heart rate than that is expected for a given body temperature. And the classic condition associated with relative bradycardia is the enteric fever that is caused by Salmonella typhi. But remember, enteric fever is not the only condition associated with relative bradycardia, and there are a list of infections that may be associated with relative bradycardia. And why do I say maybe? It's because, see, you look at this table. You can see the causes of relative bradycardia. This is the table from Harrison's textbook of internal medicine. You can see there are infectious causes and non-infectious causes that can cause relative bradycardia. Among the infectious causes, you will have gram-negative bacteria, which includes Salmonella, Francisella, Brucella, Coxiella, Leptospira, Legionella, and Mycoplasma. Tick-borne organisms like Rickettsia, Aurantia, Babesia. Others like Corynebacterium plasmodium species. Viruses like yellow fever virus, dengue virus, the various viral hemorrhagic fevers, and viral myocarditis. And you've got certain non-infectious causes as well. The point here is, if you look at this infection, dengue infection, see, in dengue, you can have tachycardia, especially, even in a context of a normal dengue fever, as well as when there is a myocarditis as well. But the point you've got to understand is sometimes dengue may be associated with relative bradycardia, sometimes. So if you look at this table and also the given options, you can see that the options A, option C, and option D, they may be associated with Faggot sign, but not option B. So the answer is going to be Pseudomonas aeruginosa. Okay, Pseudomonas aeruginosa. So once again, please let me know in the comment section if you have if you have got this right. How many of you have got this right? I just want to see how many of you are so well read. Only if you have read all the causes of Faggot sign, you can answer this properly. I just want to see how many of you have answered this correctly. Okay, just raise your hands in the chat box. Okay, right. Moving to the next question, question number 3. Pulsus paradoxus is seen in all the following conditions except. Now, again, somebody has to be well read to answer this question properly. So the options are pregnancy, thyrotoxicosis, hemorrhagic shock, and massive pulmonary embolism. So let us see the causes of pulsus paradoxus. So in my lectures, in the DocTutorials app as well, in the pulse module, I have listed the causes of pulsus paradoxus. Most important one, cardiac tamponade. Then you may also see in constrictive pericarditis, acute exacerbation of respiratory conditions like asthma and COPD, massive pulmonary embolism, hemorrhagic shock, SVC obstruction, and tension pneumothorax. So from this list itself, you have already eliminated 2 options. It is not hemorrhagic shock. It is not massive pulmonary embolism. They're asking except. Now, what to choose between pregnancy and thyrotoxicosis? Can somebody tell me in the chat box? What to choose between pregnancy and thyrotoxicosis? What to choose? Remember, pulsus paradoxus can be pathological and is most often pathological, but sometimes associated with obesity, okay, associated with obesity, and also sometimes associated with pregnancy, you may get pulsus paradoxus. Okay, so In these two conditions, you may get pulsus paradoxus. Whereas in case of thyrotoxicosis, you do not usually get pulsus paradoxus, and all what you get is a bounding pulse. You get a bounding pulse, but not a pulsus paradoxus. And hence, the answer for this question is option B, thyrotoxicosis. Okay, right. So let's go to next question. So for the previous question, I think Dr. Mohammed, Dr. Amal Chandran, Dr. Anuj Kumar Chaudhary, you have got this right. Happy to know that. How many of you have got this one right? This is actually a tough one because I've put this question slightly tough. This is actually there in Braunwald's cardiology. I just wanted to put one or two questions which are slightly tough. Let me see who have answered this correctly. Okay, right. But you see, in almost all Monday midday exams, I put 5 simple questions, 2 or 3 which are in the moderate range, and a couple of them which are slightly tough. I think you can group it into a slightly tough question, this one. Okay, so don't get demoralized in case you got this wrong, because in any exam, a couple of questions will be slightly tough. Question number 4, a Biffid pulse with the second pulse diastolic in timing is seen in association with. So what are the 2 important types of Biffid pulse that you know about? One is pulsus bispheriens, and the second Biffid pulse is the dicrotic pulse. So here they've asked about a type of Biffid pulse where the second pulse is diastolic in timing. So they are referring to the dicrotic pulse and not the bispheriens pulse. Okay. So I'm eliminating hypertrophic obstructive cardiomyopathy as well as chronic severe AR, which are associated with bispheriens pulse. And so the second pulse is systolic in timing. In case of aortic stenosis, it is usually a pulsus parvus et tardus. So I'm eliminating that options as well. So now it's simple. It's going to be option D, patients on intra-aortic balloon counterpulsations. So IABP, you can see the image of a normal pulse character in comparison to a dicrotic pulse. And can you see the definite peak in the diastole? Yes. And what are the conditions associated with dicrotic pulse? As I've told you in my lectures, cardiogenic shock, hypovolemic shock, sepsis, and also patients on intra-aortic balloon counterpulsation. Okay. So here, answer is option B. Okay, right. Moving to question number 5. Again, a basic physiology question. The character of a pulse. Okay, the question is regarding character of a pulse. It depends on what all factors. Stroke volume, does it depend? Yes. Does it depend on the vascular compliance? Yes. Does it depend on the systemic vascular resistance? Yes. And the answer is going to be all the above. Okay. So the character of the pulse depends on all these factors. Okay. Right. So I think we are done with that question as well. Okay. Right. Moving to question number 6. And this is again a question which I want to know how many students have got this right. So impaired calcium cycling is the predominant mechanism underlying. Is it pulsus paradoxus? Is it dicrotic pulse? Is it pulsus alternans, or is it anacrotic pulse? So this is an important point. See, impaired calcium cycling is the mechanism that underlies pulsus alternans. So you know that in case of pulsus alternans, you have got alternating high volume and low volume pulse. Okay, alternating high volume and low volume pulse. And this can be seen in association with left ventricular dysfunction. But the predominant mechanism that underlies the pulsus alternans, the reason for this morphology change is because of impaired calcium cycling. Okay, and that causing affection of the action potential duration. So answer is option C. Okay, this is a point I think I've stressed in my DocTutorials lectures as well on the module on pulse. Coming to question number 7. Irregularly appearing Canon A waves in JVP are a feature of. So if you look at the option, you know that in case of atrial fibrillation, there is absent A wave. Absent A wave. In case of pulmonary hypertension, you get giant A wave. So I am eliminating these 2 options. Okay, because they have asked about Canon A waves. So option A, complete heart block, as well as option D, junctional rhythm. Both of them can produce Canon A waves. But the question specifically is on irregularly appearing Canon A waves. So this irregularly appearing Canon A waves, they are a feature of complete heart block. So it is in complete heart block, you will have irregularly appearing Canon A waves. Irregularly appearing Canon A waves. In junctional rhythm as well, you will have Canon A waves, but that will be regularly appearing Canon A waves. Regularly appearing Canon A waves. So answer is option A. Coming to question number 8, not a JVP finding in tricuspid regurgitation, absent X descent, prominent Y descent, absent V wave, and the Lancesi sign. So can I see how many of you are going to get this correct? So let me know what is the answer for this question. So regarding each of the options, see, regarding the first option, absent X descent, what do you think? Is it a cause or is it a finding, JVP finding in tricuspid regurgitation, absent X descent? What do you think? Let me know in the chat box. Yes, X descent is absent in case of tricuspid regurgitation because, because of the regurgitation, the atria is not getting enough time to relax. And since the atria does not get time to relax, you will get the X descent to be absent or decreased. Next is a prominent Y descent. Again, because of the volume overloading of the atria, more blood will actually come to the ventricle. And yes, you will have a prominent Y descent in case of tricuspid regurgitation as well. Okay, right. So that is also clear. Absent V wave, that is not right. In fact, that is not a JVP finding because what you get in case of tricuspid regurgitation is a giant V wave. Giant V wave. Okay, giant V wave. Okay. So Lancesi sign is the appearance of the CV waves. Okay, CV waves because there is no X descent. So you'll have CV waves producing a large systolic jugular venous wave, and that is called Lancesi sign. Okay, so that is also a feature of tricuspid regurgitation. So the answer is going to be option C, that is absent V wave. As Dr. Gagan Surathi is saying in the comment section, he has correctly spotted out the CV waves, which is the Lancesi sign. Okay, absolutely right. Moving to question number 9, choose the wrong match. So W sign is actually a finding in case of constrictive pericarditis where you get prominent X descent and Y descent. So I'm not going to pick that as the answer. Absent Y descent is a feature of cardiac tamponade, so that is not the answer. Kussmaul sign can be associated with right ventricular infarction. Yes, because that would cause a right ventricular volume overload. Because you know that in Kussmaul sign, there is a rise of JVP on inspiration. Okay. So normally there would be a fall of JVP, but in Kussmaul sign, there is positive. So when there is a right ventricular dysfunction, as in case of RV infarction, you can get a positive Kussmaul sign. So that is also not the answer. But when you get a right atrial myxoma and there is obstruction of flow of blood from the right atrium to the right ventricle, that would actually cause a slow Y descent and not a fast Y descent. My answer is going to be option D. This also I want to know how many of you got this right. Choose the wrong match. It's not fast Y descent. It is actually slow Y descent that is seen in case of right atrial myxoma. Okay, right. Again, question number 10. Hepatojugular reflex is positive in systemic hypertension, impending heart failure, hypovolemia, and atrial fibrillation. So hepatojugular reflex or abdominojugular reflex. Tell me what is the answer. Hepatojugular reflex or abdominojugular reflex. So this is actually a reflex that is used to elicit venous hypertension in patients with impending heart failure. Okay. So when you get a sustained rise in the venous pressure more than how much? 3 centimeter. So which is sustained for 10 to 15 seconds. That is when you say there is a positive hepatojugular reflex, and that is a finding of impending heart failure, which is option B. Okay, right. So that's it on the discussion of the Monday midday quiz questions. So can you please let me know in the comment section what is your score? It's just for me to know what is your score. And I hope that you are enjoying the Monday midday quizzes and you are studying the topic. And even if you're not the winner, it is an opportunity for you to finish a topic and just go into the depth of a particular topic as well. You tend to study that particular topic in detail. So can I know what are your scores? Anuj, Amal, Nitin, Nafisat, Praveen. So Nitin has got 7 questions correct out of 10. Nitin, that's a good score. Definitely a good score. Nitin Janagam, good score. What about the others? What about the others? Waiting for your scores as well. So Hariharan, you have got all 10 correct. Very good, Hariharan Tangamuthu. Hariharan, you're from which college? Amal Chandran, you have got 9 correct out of 10. Praveen, don't worry. Just prepare again for the next exam. Anuj also, you have to prepare well for the next exam. So any score above 6 is fine. Okay, if you've got 6 correct, that's fair enough. 6 correct, fair enough. And suppose your score is 5, 4, don't worry. It just means that you've got to study the topic a bit more in depth. But again, let me tell you, a couple of questions are tough only. So don't get demoralized that you could not answer a few questions. It's on purpose that, I've put a few tough questions as well. Okay, right. So that's it. Thank you so much, everyone, for joining, and see you for the next Monday midday quiz. And one second. I'll just list down my Instagram ID as well. You can ping me for any queries there. Dr_Rahul_Rajeev. Okay. Right. Okay. So once again, let me tell you that, the winner of the quiz will be selected based on the top mark. And a few students, I know that you do cheat in the exams by using 2 devices. But again, only the deserving person will be given the prize. We'll be checking the duration of the questions answered by each of them. And because we can actually see it in the back end by the technical team. So only the deserving candidate will be given the prize. And because we want to make sure that the competition is fair enough. And we do respect the students who have put in genuine effort for the quiz as well. So, all right, thank you so much. And Praveen, I'll let you know for the topic for the next week. Maybe tomorrow or day after, I'll announce the topic for the next week. Thank you so much. Bye.